Hello, and thank you for joining us today. And welcome to series on health information exchange and public health. We are focusing today on data sharing to improve health equity. I am Timmy Leslie with Blue Path Health, and we're pleased to feature this event as an effort of connecting for better health, a new coalition pulled together through health plan participation, providers, patient advocates, and also additional healthcare stakeholders that are united to improve health information and health data infrastructure in California. You can learn more about us at connectingforbetterhealth.com. We'll go ahead and put that in the chat link. We have a pretty large group today, so all of you are muted, and I encourage you to use our question and answer feature to ask questions for our panelists. As part of Connecting for Better Health, we are also storytellers and looking for ways to really take home the need for better health data infrastructure in California, both from the patient and provider perspectives. And just hot off the press, we have a new story and a video that we'd like to share with you just to be able to kick things off today. And I'm going to look to Kira, my colleague, to begin that video. Thank you, Kira.
I am a family and community medicine physician. I am the medical director at Sacramento Native American Health Center, and I provide primary care services from pediatrics to geriatrics. When you are presented with a patient that clearly is in need of help, but you're having to wait for records to determine the next step, it doesn't necessarily hurt me individually, but the patient is potentially hurt significantly as they wait. I had a patient who I saw last year who said, yeah, I was in the hospital and they said I had a stroke. In my mind, there's certain things that I think that the patient is going to need after having a stroke. What medications do they need? Are there specialists that they need to be following up with? I requested the records 3 or 4 different times and did not get them. In waiting for those things, that was 3 or 4 months that the patient wasn't able to get those services. I still followed the patient and he still has limitations that I'm not convinced he would have had otherwise. The number of times in which we get the same labs over and over again, simply because we don't have access to the labs previously, or there's not an easy health information exchange to import those labs into our system, is ridiculous. Simply trying to get the records from outside entity or get a referral through is a painstakingly slow process. And in the meantime, the patient is the one that's suffering.
Thank you, and I think it really grounds our discussion of the need for data exchange and our policy discussion that we're about to have today. And I couldn't be more pleased to be able to partner with our moderator, Dr. Hector Rodriguez, who's a professor of health policy and management at UC Berkeley, across the Bay here, and also the director for the California Initiative for Health Equity and Action. And I also have just been a pleasure working with Hector as we plan today's event. I'm always amazed that whenever we reach out to pretty much anyone, that Hector has been part of their either academic career or working with them professionally as well. Hector, I'm going to hand it over to you to introduce our panelists and get us kicked off today. Thank you.
Excellent.
So much.
Thanks, Timmy. I'm really excited for the panel today, featuring the perspectives of colleagues at the forefront of health information exchange in our state: Alice Chen, Medical Director of Covered California; Julia-Adler Milstein, Professor at UCSF; and Rhonda Smith, Executive Director of the California Black Health Network. Cal-IHEA is really proud to co-host this event, emphasizing the importance of data sharing to advance health equity. Today, we're really going to focus on a couple of issues. One, race, ethnicity data and language data, and the extent to which those can be used to help target interventions and help reduce disparities. Two, how do we really improve trust in data collection and data sharing? You know, there's been histories of patient data not being used appropriately, and that really is disproportionately affecting Black Americans. And how do we build that trust to enable this exchange of data? And the third thing is, how can we leverage the data from a health information exchange to help us respond better to pandemics and really focus resources and support to the most vulnerable communities in our states? So as part of Better for Connected Health, there's a third webinar in this series that's going to focus razor sharp on social services. And while that's important to addressing disparities, the scope of today's conversation is really around race, ethnicity, trust, and pandemic response. And I encourage you guys to join us for the panel next time in June on social services, data collection, and exchange. In order to set the stage around why this is a really burning platform issue for our state, is the national landscape suggests that California hospitals and other states with vulnerable populations are being hurt because of the lack of health information exchange. For example, in the Centers for Medicare and Medicaid Services hospital readmissions reduction program, we know that safety net hospitals and those that care for high proportions of Black patients are more likely to receive financial penalties for excessive readmissions. And if the health information exchange was available, we could really prevent these penalties from occurring, thereby advancing health equity and protecting our hospitals in California that care for our most vulnerable patients. At the same time, we know that national studies indicate that federally qualified health centers and safety net outpatient clinics are less likely to have connections to their main hospital compared to private practices or more advantaged practices. So without having a health information exchange in our state, we know that drop balls and missed opportunities, missed handoffs, fumbled handoffs, like you saw in the video, will continue to occur. And finally, we can use health information exchange information, particularly around race and ethnicity and language and other vulnerabilities, to target interventions and to tailor interventions to do really a precision population health approach to advancing health equity. We can disaggregate the data and really enable analysis of the impact of intersectionality on health disparities and how to prioritize policies and interventions to tackle those most vulnerable in our communities. And so one key question that we're going to grapple with today, and I'd ask our speakers to really address this, if we're going to advance health equity in our state, and it's really a goal that we're committed to, what should our state be doing to prioritize policies and solutions with respect to an HIE? How should it look? How should it be rolled out? What things should we be attentive to as our state moves forward to advancing a health information exchange? Just a quick additional notes about the speakers. Julia-Adler Milstein at UCSF is a professor, and she is a national expert, probably the best expert in the country on health information exchange nationally and models that work and interoperability. Dr. Alice Chen is Chief Medical Officer for Covered California. And in the past, her past position, she was Deputy Secretary for Policy and Planning at the California Health and Human Services Agency, where she played a central role in the COVID response, and she'll be talking about those experiences. And then finally, Rhonda Smith, who's the Executive Director of the California Black Health Network, will talk about the impact of an HIE in advancing Black health equity in our state. The California Black Health Network is the only Black-led statewide organization dedicated to advancing health equity for all African Americans and Black immigrants in our state. So I'd like to turn the floor to Alice Chen, who will be our first speaker, talking about real-world examples of how an HIE could have been leveraged during the pandemic in addressing needs of vulnerable populations.
Great, thank you so much, Hector. As Hector mentioned, I'm currently at Covered California, but was at the Health and Human Services Agency all last year and wanted to share some reflections based on our experience responding to COVID. So we've known since we started looking that there are disparities, but there's a reason that we're talking about data sharing and health equity now, and that's because COVID has put both of those things front and center for us. And when I reflect back on California's track record over the past year, I'd say that in many ways we've led the country in terms of embedding equity as a centerpiece of our response, but we've really been hampered by our size and decentralized structure, both organizationally, institutionally, and very much on the data front. Next slide. So when I think about our work last year, data issues loom very, very large. These are screenshots from April, early April of last year. It seems like a lifetime ago. On the left side was one of our very first models, predictive models, about projections for hospitalizations. And remember, we didn't know a lot about COVID back then, and you can see that there is a huge range. The worst case scenario was 700,000 peak excess hospitalizations in a state that has fewer than 70,000 beds, most of which are usually full. And on the right side, you'll see that we were desperate for real data. Those are the little red dots at the bottom to figure out which of these curves was going to be our future. And it was truly like reading tea leaves and hoping for the best, planning for the worst. I remember calls around the clock with local county health officers, CEOs, and CMOs of hospitals and health systems, trying to get a reality check of what was happening on the ground because our data was so sparse. An enormous amount of our focus in those first 6 months was getting timely, accurate, complete data, whether it was for testing volume, cases, hospitalizations, or ICU stays. Next slide. And so we actually had the foresight very early on to work with the California Hospital Association to create a system where we aggregated data from all 416 acute care hospitals up and down the state. And it felt like months, but I'm sure it was only weeks before the feds started collecting the same data. It is hard to believe, but we created a daily manual data entry system, which actually served us remarkably well, but as you can imagine, was subject to all sorts of human factors, fat finger data entry errors, changes in staff, or being short-staffed, which is what we experienced in July. So during that surge in July, when we need the data most, two things happened. One was HHS decided to change a lot of the data fields and data definitions, confusing a lot of the frontline staff. And our hardest hit hospitals were so short-staffed, they didn't have people available to reliably enter data. And so we ended up, one of my colleagues said, it's like you're going 70 miles an hour and you hit a fog bank. And so we ended up having to reach out to our colleagues in statewide hospital systems like UC, Kaiser, Adventist, Dignity, Sutter, to get their system-wide data in order to serve as a proxy and corroborate what we were seeing. And we use this data in very real ways to allocate remdesivir, monoclonal antibodies, inform the deployment of many resources, including our ICU strike teams. Next slide. So, where did health equity sit in this context? In the very beginning, when we started looking at our data, we knew that given the patterns of infection, what we were hearing from the field, there were likely to be disparities. But the data initially showed that case rates were lower in communities of color. And we knew immediately that was because of disparities in access to testing. And as the pandemic progressed, it became very clear that COVID was going to be defined by disparities. But despite mandates to collect race and ethnicity data and subsequently SOGI data, it remained quite incomplete. In August, when we were developing the blueprint for a safer economy, 50% of tests and about a third of cases did not have associated race and ethnicity data. But every tested case had an address and a zip code. So that's in large part why we ended up using the Healthy Places Index as our marker for equity, which for those of you who don't know is a place-based composite of 25 different measures across 8 different domains like education, transportation, housing, healthcare. And for each county, what we did was we took every census tract, ranked them by their HPI, and the lowest 25% was considered the health equity quartile. And so every county, in order to move forward in the tiers and open up their economy and their different sectors, had to both demonstrate that they were targeting vulnerable communities in the health equity quartile, dedicate a certain proportion of funding there, and in fact couldn't actually progress unless their quartile was not substantively different from their overall county performance in terms of case rates and test positivity. Next slide. At the same time, the state continued to focus on completeness of data I encourage you guys to go to the COVID-19 California website. At this point, you can see that the missing data for tests has dropped from originally 50% to about 37% for cases, down to 13%. So we still have work to do. And if you were to look at the SOGI data, it is still very, very incomplete. Next slide. So this is my last slide, and I'll end on a few take homes. I think first, our experience is that we can create policy that incorporates equity in a data-driven fashion, but we absolutely need better data, more complete, more timely data. Secondly, it is long overdue, but we need to address the longstanding public healthcare divide. In the big scheme of things, hospital data is easy. Last year, one of our big challenges was ensuring all testing data was being reported centrally. Now it's about COVID vaccinations. There's mandatory reporting no matter where the vaccination is given, but now we have to feed it back to our health plans and our health systems so they can close the loop with their enrollees and patients. Third, we'll be talking about this later, but we need both real-time and aggregate data. We need it in automated ways that don't depend on brute human work hours. And then I know this is going to be a focus of our conversation. We need a statewide initiative on improving the quality and completeness, the accuracy of our race ethnicity data. And this means, I think, multiple things. We need cross-sector engagement across purchasers, payers, delivery systems. We need to engage the public to help them understand why we need this data, why they should self-report. And lastly, we need disaggregated data. We are a very, very diverse state, and the categories that we have right now don't do our communities justice. So I'll stop there and look forward to the discussion.
Hi everyone. I'm Rhonda Smith. I'm the Executive Director of the California Black Health Network, and I appreciate the opportunity to participate in today's program. And I wanted to just talk about our mission and the campaign for Black health equity and how important the health information exchange is to our work. And so we work every day to ensure that Black Californians, regardless of how much money they make, where they live, who they love, what country they're from, has access to quality, equitable health care, and ensure that they don't succumb to diseases unnecessarily. And so with the campaign, our goal is to decrease health disparities and also improve life expectancy of Black Californians. Unfortunately, as others have mentioned before me today, COVID has really exacerbated the health disparities in the Black community and also shortened the life expectancy over the last year. So nationally, I believe that life expectancy has decreased by about 3 years. In California, it's about 1 to 2 years. And so the work that we do under the campaign for Black health equity is really aimed at achieving that improvement by breaking down barriers to access quality care, equitable care, as well as timely care. If you recall from the video with Dr. Hakim, he talked about a patient who had a stroke, and he didn't find out right away because of some of the inefficiencies and lack of transparency within the system of care. And so, health disparities and trying to close the gap in health disparities is a very complex issue, but having access to patient data can certainly help get in front of issues, stay on top of issues, and address health concerns and issues that patients do have. And so I also know of one other situation with a patient of Dr. Hakim's where she had an injury to her shoulder and required surgery and had been shuttled around to different doctors and specialists and really had to go through the process all over again at each experience. And so for her, not having access to her own information to really understand what was going on with her was very frustrating and stressful. And then when she went to see providers, it really caused more concern and delays in her care. And so it took an extra month or two for her to get the surgery that she needed. Had there been easier access and more availability of her health records, that would have been much more of a seamless process and she would have been able to get into her surgery a lot sooner. And so she had to endure more pain as a result of that, taking more medication as a result of that, because of the inefficiencies in the system. And so for us, as part of the Campaign for Black Health Equity, also, we are addressing those issues to break down barriers at the individual level and the system level as it relates to the health information exchange. We are very strong proponents of patient empowerment and participatory medicine. Having access to patient records is one way to achieve that at the individual level, at the system level. We believe that it really promotes better provider-patient relationship and communication, better decision-making on behalf of the patient by the physician or provider, and also can impact healthcare costs. We heard some examples of that earlier. And then I think the most important part is just eliminating the inefficiencies that exist. We know that unfortunately the healthcare system in our country is not the most perfect system. There are already issues to begin with when it comes to outcomes. We spend the most on healthcare of all developed countries, but unfortunately we have the worst outcomes. And even at birth, we have the worst life expectancy compared to most other developed nations. And we spend the most on healthcare costs in general and on a per capita basis. So you're talking about inefficiencies in a system that already exists. On top of that, in terms of trying to get access to information, makes it even more complex and more difficult to provide the kind of quality care and timely care that especially folks from underserved communities and communities of color really need. And so we are working every day in partnership with some of the folks that are on the panel with me today to really ensure that we break down those barriers and improve the quality of care and accessibility of care and the timeliness of care, because we know that at the end of the day, that is the main way or one of the main ways to ensure that there's a decrease in health disparities. And also, I think something that Alice mentioned that is also important, and I always talk about, to decrease disparities or to really have an impact on disparities really takes a village. And so Alice, when you talked about it takes payers, it takes patients, it takes providers, it takes policy, it takes the public and partners in this process to really work together to begin to dismantle all of the barriers and all of the issues that create this complex system of health disparities. So hopefully this will be one step in the right direction in terms of having more open access to patient healthcare information and records. And we'll continue to work on behalf of our constituents across California to make that happen. So thanks again for the opportunity, and looking forward to hearing the rest of the discussion today.
Terrific. Well, thank you for those two sets of comments. It's hard to know what's left to say because they were both so excellent and broad-reaching. So, as someone who spends a lot of time thinking about health information exchange, I'll just perhaps add a few additional comments. So one is that, why do we find ourselves having this conversation in 2021 after there's been, so much time and effort and resources devoted to digitizing our healthcare system? And it's because we've largely digitized around the silos that exist. So we know that our healthcare system is extremely fragmented, and we've essentially replicated that fragmentation in an electronic way. So as Alice was referring to data that's missing, I would suspect that data is not missing. It exists somewhere, but the challenge is figuring out where and how to get it to where it needs to get to help inform decision-making at that moment in time when it's so critical. And so when I think about health information exchange, it's sort of two pieces. It's moving data to where it needs to be, and it's also aggregating it in ways that are useful to different types of decision makers. And so we saw the two use cases that are sort of the classic HIE use cases presented. So Dr. Hakim talked about the need for a frontline physician to get past medical records about his or her patients. We know that we need to get clinicians that. And we actually know today that a lot more of them are getting that data than even just a few years ago. But the problem is that ability has been implemented unevenly. And it's the better resourced settings that have been the ones that have been able to improve their interoperability. And that's leaving behind perhaps the providers that need it even more. And so we do need to think about how do we ensure that settings that have electronic health records that are digitized help to catch up to others in terms of their interoperability capabilities. There's a whole set of policy efforts that are trying to do that at the national level. And I think there's further opportunity for the state to advance that. But there is a lot of HIE infrastructure that exists today. And so when we talk about building a new state HIE, I do start to get worried because I think it's really important to see what we have and what's going to come, and then think about what are the additional pieces that need to be layered on in and around that. I also want to comment on the use case around public health needs. I think we have a rare and really important window to address that because the pandemic made so plain how far behind our interoperability what capabilities were to meet the needs in a pandemic. And so, I think we now understand with excruciating detail, not just the type of data that we need, but how the data needs to be connected. So it's not enough to be able to know who's gotten tested for COVID, but we also need to know for each given test to connect it to that patient's demographic data. And so again, that's where I think, what we realized is it's not just about looking at data types individually and saying, okay, well, we know, how many deaths there were or how many COVID tests there were, but we need to be able to cut that by all of these key features and demographics. And even though we saw on the slide that they were able to look at that data by by sort of equity quartile, it sounded like, that had to be drawn from geographic regions rather than actually tied to the individual, him or herself. And so again, that's likely because we didn't have the ability to tie those two types of data together. So I think that we really are at a unique moment of being able to understand what some of the interoperability needs are, and then to be able to focus specifically on how to build capabilities that allow those data to come together in a much richer way and give us insights into the equity challenges. I will just also note that the Office of the National Coordinator for Health IT is funding a set of HIEs around the country to address some of the specific public health needs. And so I do think those will be important examples for our state to look at, to understand what they're learning and where's the opportunity to model some of the success stories. And in fact, one of them in Georgia is essentially doing just that. How do we connect medical and demographic data to test result reporting data so that those can travel together? Last but not least, let me just close by saying that HIE should be the ending point, not the starting point. and let me explain what I mean by that. We talk about HIE as if that solves the problem. And really all it is an enabler, right? So moving data around in and of itself is not going to do anything to improve access or equity or any of these other things, right? That's going to take a decision maker making a different type of decision about how to allocate resources or whether a patient needs a test or not. And so I think we really need to start with the endpoint in mind. What are the types of decisions today that are either suboptimal or not able to happen in a timely manner? And then think, okay, well, what data do they need to inform that decision? And how do we get them that data at the point that is relevant to the decision? If we start by building the HIE and then hoping that things will fall into place after that, I think we've seen time and time again that fails. So we really do need to start by thinking about what is the broad problem we want to solve, and then working backwards to understand how a state HIE could help support solving that problem. So again, I think it's an exciting moment in our state to be able to think about what a state HIE can do, but let's be sure that we're building it with the end goal in mind.
Excellent. Thanks for those great presentations. I'm going to start out with some questions for the panelists, if you can all turn on your videos. I'm going to direct this one first to Alice, and then If Julia or Rhonda, you have additional comments, I'd love your additions to the response. The first question is, Julia raised the challenge of, oh, it kind of scares me that there might be this separate initiative, state HIE, and we've had a lot of history around regional health information exchange. Some have been pretty successful. The one that comes to mind is the Inland Empire experience. And I do wonder, what is our pathway to getting full coverage in the state in terms of common data elements being exchanged? Is it this continuing to fund this regional approach? And if we're really interested in health equity, does it mean that we target communities that maybe have a foundation of electronic capabilities, but then need the extra technical assistance to kind of share the data? How does the pathway look for our state, Alice, in terms of the roadmap? If we were going to invest in technical assistance or local dollars, how would that look like? What would be the best way to achieve equity? Or is it a top-down, more centralized approach that would be better?
Well, what's better and what's possible, I think, are two different things. I think, again, California is so huge. We oftentimes talk about it as a nation state, but I will just say, having gone through COVID, having had to coordinate with 58 different counties, we truly are a bit of a nation state, and we do encompass incredibly different communities, political orientations, geographies, healthcare infrastructure. I do think to get to where we want to be in our lifetimes, we have to build on what we have. And so I do think that there have been some really robust regional successes. I do think we need to pull it together. I do think there needs to be a governance structure that is a multi-stakeholder and public structure. Because again, when you talk about data and we talk about how fierce the competition is across these different sectors, you really do need to have a bit of a neutral party to broker some of the direction and decision making. I do think the other piece is, if we're talking about equity, we really have to be data driven and intentional in how we phase it in and where we start. And to your point, I do think we also have a really robust safety net system in our state that is comprised of FQHCs and public hospitals. I still practice at San Francisco General Hospital. We talk about the digital divide in terms of individual patients, but it's just as true at the health system and health delivery level. I mean, I'll say most of my colleagues in the public hospital system and in FQHCs are still doing telephone visits. When I have virtual clinics, so I have clinic in person alternating with virtual, my colleagues at the UCSF Parnassus campus are doing video visits. I'm doing telephone visits, oftentimes with an interpreter, doing a three-way without any visual cues. We do need to invest both in infrastructure, but more specifically with HIE in our safety net. And then the other pieces, I know there's a whole nother session coming down the line on social service agencies, but that is a key part. If we're talking about equity, I'll just say in San Francisco, one of my dear colleagues, Maria X. Martinez, had a vision 20 years ago of bringing together data from our hospitals, our clinics, mental health, substance use, jail health, shelters, homeless health. It took her 20 years. She unfortunately passed away last year, but it's only now getting traction with Cal-IHEA. And so again, you can't boil the ocean, but we can't not plan with the end in sight, as Julia said. And we have to make sure that the social services component is part and parcel of our initial orientation and planning.
So I heard a couple of nuggets. Build what we have, don't recreate the wheel, build on successes, regional successes, and learn from them. We need a governance structure that's impartial, that can adjudicate maybe conflicts or challenges, and targeted investment in the safety net to improve their capabilities. Others, how about Julia or Rhonda, any additional insights? What does our path potentially look like to advance health equity? If health equity is a priority, how should our building of the HIE for our state ultimately look like?
Well, I'll just say, I think that, so I wasn't born and raised in California. I'm a transplant, so relatively short period of time here, but I find it really interesting that, with, Silicon Valley and here in LA, Silicon Beach, that there hasn't been much of a public-private partnership when it comes to addressing this issue. It just seems like, there's a lot of brain power and capability when it comes to technology and being able to leverage that technology to have an impact on, the way things are or not happening at the system level. So I find it really interesting that that has not happened yet. And maybe there are some things in the works that maybe it's much more political than I'm aware of, but it just seems like somewhat of a missed opportunity, kind of being somewhat of an outsider looking in and knowing, from the time that I lived my life on the East Coast, we always look to California to be sort of the bellwether for what's going to happen for the rest of the country, but I haven't seen it happen so much in this regard. So I don't know if any of my colleagues on the event today that are here have any perspective or insight around that. No.
I mean, I think in some ways it gets back to the point about how big and heterogeneous California is. And so there are some ways in which I think we are, a model, and other ways in which, we're certainly not leading the pack. And so I do think there is no place, frankly, I think on earth that is the interoperability, sort of heaven. Everyone's always like, well, where do we look to see how it could be done right? Like, I've yet to find it, and I've spent a lot of time looking. And so again, I think it's all about sort of figuring out like which problem you want to solve first, and then getting stakeholders to come together and agree to work on that. And I guess to that end, I do think that the convening and the neutral, convening space is really important. But again, what I've come to observe is that there's sort of two pieces that are really critical. There have to be incentives, like there have to be teeth in it for the organizations that you're asking to do really hard work. And again, if it just feels like we're just doing this because it's the right thing to do, again, I don't want to sound cynical, but I just think we learn time and time again that what gets attention and speed and movement is when there are dollars left on the table if you don't do something. So like we have to get strong incentives to engage. And I think that often has to come from the policy side of the House. Though again, coordination among commercial payers and others, I think there are other successful models. And then I think on the full other end of the spectrum, like we have to be really, really good about like the boring data housekeeping, data standards side of things. Like if the data is not going to conform to standards and we're not going to hold people accountable to the cleanliness of their data, then it's like we just spend so much time like sort of working with these messy data and not actually getting to the value of the data. And so in sort of my future idealistic state of interoperability, there's really strong incentives, and you only get incentivized if you provide data that is like machine readable from the start. And if a human has to look at it and make sense of it, if we're talking about fat fingers, like we failed. Like that is not interoperability.
Yeah. No, and I just want to add, I think whenever we talk about technology, particularly being based in the Bay Area where there are so many startups, there's so many shiny new objects, there's so many like silver bullets that are flying around, you have to duck, is that when we were preparing for Epic, I still remember one of our consultants saying, if you don't clean up your data and you have crappy data, you put in an EHR, and it's the same with an HIE, you have crap moving at the speed of light. Like nobody wants that, right? And so I think really, part of it is getting back to basics, and we've never been good at the basics. We have to make sure that that's a focus even as we build the interconnectivity.
I'm going to shift gears a little bit and try to address some questions that are coming in through the Q&A. One that's pretty central, and Julia and Rhonda, I'm looking to you in particular for your perspectives on this one, but the issue of trust has come up repeatedly, and communities of color and their trust in sharing information that could be potentially used against them to deny them benefits or to deny them care or to put them on a list of problem patient. So can you tell us, how do we get there in terms of hesitancy to be willing to support a data exchange at the individual level? Should there be options for patients to opt out of these exchanges or not? And how might we support, educational efforts or other ways to educate or, improve trust? Or are there other things we should be doing?
Do you want to go first? It's such a key question, but it's a really, really hard question too. I mean, I guess I'll just reflect on what I've seen, which is that there's no one right way to do trust. And that's because, different, individuals, different groups, they feel very differently about these issues. And so I think we need to understand the perspectives. I also think that there is internal inconsistency in what people say they want and don't want. And so that makes it hard because on the one hand, they want their doctors to have full access to their records and they want to be, be given efficient and, equitable care. But then when you say, are you comfortable with your information being shared? They'll say no. So, it just makes it really hard to know sort of like what guides this and like what constitutes a process that makes you feel confident that you are gaining trust. I mean, I think there's basic things you need to do around ensuring that, your security protocols and that, the data is not getting into the wrong hands. That's like obvious, I think, to be sure that the data is secure when it moves. And I think we just need to be able to show that we're providing value with the data. Because I think what doesn't feel good is to know that your data is being shared and you're not seeing the value of it, or worse, it feels like it's being used in a way that doesn't provide value to you. So I think that is really key, is to think about what value do we give back to consumers to show them that allowing us to use their data is benefiting them. Personally, I think we've seen there's a lot of challenges with opt-in models. Opt-out, I think, is, again, speaking in very broad brush strokes, the way to go. But again, we need to show that we deserve that by creating value as quickly as possible. And people are willing to give up a lot of privacy and a lot of data when we deliver value to them. I mean, we've seen that, in our Silicon Valley neighbors repeatedly. So again, if we can use the data for good and do it quickly, I think we will get the trust.
And I think, speaking on behalf of the Black community, there's been a longstanding mistrust of the healthcare system and medical community in general, and in some cases, rightly so. And so, the old saying goes, like, if you don't, you earn trust, you don't just give it or get it. And so I think if, the healthcare system and the whole patient experience was a lot less transactional and more relationship driven, I think that would be the beginning of building that relationship of trust. And so it takes time to build that. And I think that comes through having more health literacy on both sides of that relationship, the patient being more health literate about healthcare in general, definitely whatever health condition that they're dealing with. On the other side of that relationship, it's about the provider being more culturally astute and having more cultural humility and being able to spend more time with the patient, so that some of the things that may not be accessible through electronic health records can be discovered just by having more, an approach of having dialogue with the patient. I'm drawing a blank on what the actual term is, but more of an interview style conversation or visit with the patient. But I think it takes time. I think having more of that open communication and transparency, definitely can build trust or cultivate that kind of relationship. But again, I like to look at health literacy as being something that happens on both sides of that relationship. So, and I think that's an important part of really building the trust and ensuring that, both parties are more culturally astute and aware and understanding in that relationship.
And Hector, do you mind if I just
of course, yes, I was going to ask you.
And the reason is because all last year, one of the mantras that we were using, whichever I think most people were saying, is change happens at the speed of trust. When we want behavior change, and trust, when you break it down, is about competence, reliability, and motive. And I'll be honest, in terms of the healthcare system, we're not very reliable. And sometimes we look pretty incompetent to patients. I mean, patients think we are exchanging data already. They think we're coordinating their care already. I mean, that's a pretty reasonable assumption. And then when you're working inside the system, like, you have no idea how much it takes for me to get your records from Santa Clara, or to really figure out what medication list you should be on. And so I think it's a pretty big lift. And I think if some of these efforts are embedded in a larger healthcare system orientation towards disparities and equity, vis-a-vis things like, serving as anchor institutions, really thinking about how we serve our communities best, not just in this HIE, IT world, but kind of writ large. I think that then addresses some of the motives pieces.
Great. Just I wanted to make sure we're addressing, these are great discussion, making sure we're addressing some of the Q&A. One that has come in is about the CARES Act and whether California HIE and federal HIE should try to align as much as possible through this CARE Act. Includes definitions and compliance and dates for information blocking as well as interoperability. So I guess it's the alignment between federal and state activities in this realm and how we might do better in aligning these two efforts.
Alice, do you want to take that one, or Julia? Yeah.
Yeah, I mean, I'm happy to start. So, I mean, information blocking, API requirements, like those predated the CARES Act. Those were 21st century cures. And anyway, that policymaking that's been in process for a while. And I do think, they provide a floor. And so I think we do need to help, ensure that our state can meet that floor. And then I do think there's opportunity to think about where above and beyond that, we can leverage that framework. And then there are others too, for example, the trusted exchange framework and common agreement that's really intended to try to connect up existing networks of connectivity. So anyway, it's my brief answer is like, yes, we certainly need to be coordinating and aligning with what's happening at the federal level. But even when you put all of those together, there will be additional opportunities where the state could move above that common floor. And again, there it's really thinking about where is there alignment and momentum to address particular use cases, or so again, whatever it may be. And that's where I think, looking to this ONC STAR HIE program to see like what have individual states taken on as additional use cases. Again, those are mostly around public health preparedness. But again, you can get a sense of where states have said, we're really going to focus on this dimension and try to do better here. And so thinking about what should California's be, I think is a really important opportunity.
Thank you. Any other thoughts on this federal alignment issue? All right. Two questions have come up about broadband access for populations and the digital divide and bringing the efforts around HIE and the digital divide together. One question was really, should we be capturing data on broadband access since it's such a determinant of health now that we're relying on remote monitoring and telehealth more? So I guess policy alignment around broadband access for patients, underserved patients, and the HIE conversation. How do these interdigitate for California? And is there, I guess the proposal from the comment here is we should be capturing data on broadband access at the individual level to be able to understand that as an element in our HIE. But also it seems another recommendation is to have this HIE conversation in tandem with the broadband connectivity so that the policies can be synergistic. Any thoughts on this? Tough questions from the audience.
I would say, I mean, they are both technology. I mean, they're, but I have to say, I agree that they both have to be prioritized, because in the end, so much of the promise of leveraging technology during COVID, the telehealth, and then now looking forward to home monitoring, particularly for chronic diseases, population management, having registries, and then hospital at home. Like those are all have incredible potential, way beyond like a synchronous video visit, right? I mean, those are the real investments we need to make, and they will be their communities will be completely left out and left behind if we don't do the broadband investments. And so, and all that data that, and I think broadband is part of the American Jobs Plan. And so that would be another piece I would say is when we look at health policy, and we need to kind of broaden our lens and broaden our scope and think about, it's not just about, the great stuff that's happening with the health insurance exchanges and making coverage more affordable, but it really is about how do we address all these kind of systematic underinvestments in our vulnerable communities.
Thank you. Any other thoughts on that issue of broadband and the HIE conversation in our state and the synergies there? All right, I'm going to go to this question about, as a state, we have some pockets of innovation and where regional exchanges have worked well, but as a state, we're challenged because of the decentralization. And we know that there's been federal investments from the FCC to clinics to enable telehealth and, HIT capabilities. And I had wondered, from your vantage point, do you feel like we're under-tapping federal opportunities as a state because of our positioning with respect to our HIE development? Could we be drawing down more federal funding, I guess, to advance our HIE if we had more of a solid plan, or if we, had made more progress? So I guess what are we opportunities we're leaving behind at the federal level, and might an HIE or beginning to work on this enable us to draw down more funds to make the HIE happen and real?
Hector, that's a charged question. I mean, again, I think it comes back to the fact that California is such a large and diverse state. And so again, we really have to think about like how, so I do think, right, if there was more sort of agreement on like what are the top priorities and where are stakeholders willing to move quickly, then yes, like there probably are some opportunities that we could be more competitively positioned to take advantage of. But again, all of this, as Rhonda said, moves at the speed of trust. And so if you're going to try to get a large heterogeneous group of stakeholders to move, that's not something you can do quickly. So I do think we're sort of in this tricky situation of we've been good about wanting to be inclusive and build that process of inclusivity and trust, but then it means that we are slower and less in alignment on sort of what are the top urgent priorities. So again, I think the pandemic has created a unique opportunity to maybe help people move more quickly. And so again, I do hope that, there might be an opportunity to do that better than we have in the past. So again, like, states that have single statewide HIEs, I mean, they've gotten there for a reason, and it does help when, there's funding, available for those types of entities.
Other thoughts on California being left out of maybe federal opportunities that we might have been able to use or can use in the future? Great.
Well, maybe not so much that, but I do want to say that, I think it's important that when it comes to, when we talk about policies, that we all participate in that process. If we believe that this is something that is important and it's going to be play a key role in addressing health disparities, then we all have the opportunity to express our voice and share our perspective on that. So we know that AB 1358 is one way that we can provide support and I guess share our voice to at least begin to focus on having better data and disaggregated data when it comes to reporting on diverse communities, because we know no community or BIPOC community alone is a monolith. And even within the Black community, and even when we talk about Black immigrants, there's Afro-Caribbean, there's African immigrants, there's Afro-Latin. And so it would really be helpful to participate in that process of making sure that, policymakers who are in positions to make decisions about these type of policies and how it can impact health disparities, that we really help, educate them as part of that process and share our voice to help move those things forward. So that would be my perspective and contribution to that.
Excellent. So we're getting close to time, and I'm just going to ask you guys another difficult question. But as we're thinking bold and statewide here, I was wondering, with this race and ethnicity data, the spottiness of it, and as you guys have all underscored, that if the data is not good going in, it's not going to be very helpful to use for monitoring or for intervention. So from each of you, I was wondering, what is one thing maybe we can do in our state, our call to action, if you will, in improving California's race and ethnicity data collection and reporting. Given that it's so central to tackling health inequities, those data, and understanding them and intervening on them, how do we get there? How do we get more complete and reliable data on race ethnicity so that it can serve as the foundation for the HIE interventions or supports?
Well, maybe I'll kick us off. Having, tried to tackle this for 15 years now, and it's pretty discouraging that we're not in much of a better place than when I first started working on this. And in retrospect, it probably isn't surprising. As a country, we don't feel very comfortable talking about race. And so it may not be surprising that we're not that good about collecting it in an accurate way. But I think two things. One is coming to some consensus about what framework and what categories we use and how we ask about it. Because again, particularly for California, to Rhonda's point, like the race ethnicity divide is, in my mind, a very East Coast construct. And I think we need to be able to tailor it in a way that really makes sense for Californians without losing the granularity and the kind of specificity that we need. Again, no community is a monolith, but coming up with standardized categories and then figure out how to ask about it. And I actually think that we would really benefit as a state, if this is really important to us, to actually have a public awareness campaign to really educate communities about why we're asking about this, our motive behind it, give them examples of how it's been used to people's benefit, to communities' benefit, so that you even have consumers and patients raising the issue rather than us trying to pull it from people.
Excellent points. Any last things to add, Rhonda or Julia? We're at time, and but any couple seconds.
No, I think that's a great point that Alice raised. When we talk about the trust issue and really being patients being willing to share data, I think that would be one solution, maybe not the only thing, but definitely a great idea to help educate and build awareness, and then I think promote more trust in terms of sharing information and what that really means.
I'll just come back to my triumvirate: trust, standards, incentives, and just incentives to adhere to the standards, right? We can have perfect standards, but we need people to feel incentivized to use them and implement them in their day-to-day work. So
if we had more time, I would ask you to unpack what you mean by incentives. There was a thing there, but maybe for another time. Going back to Timmy, thanks for such a great, hosting such a great panel.
Well, thank you. Thank you everyone for being here today. Hector, fabulous working with you to be able to pull this off. Rhonda, Alice, and Julia, I've learned so much from today. I know all of you that participated as attendees also learned a lot of nuggets, more than nuggets, and trust, incentives, and will. I'll add will. It'll take us far. So thank you very much. And for those of you who are interested in our next panel, we are aiming to have it the first couple of weeks of June. So look for the date when we will announce it. As well as if you'd like to join the coalition, we are open to all, and we are constantly looking for ways to be able to get the word out, educate, and be able to pull stakeholders together to make forward progress. So again, thank you very much. Have a great day, and thank you.